So in the next 15 minutes here, we're going to talk about the diagnosis and management of shock. Now, I think this is probably one of the most important lectures, right? A, because one, I'm giving it. Two, because I think this is something that we're confronted with, on a routine, daily basis, in the surgical intensive care unit. So what we're going to do is we're going to talk a little bit about the categories of shock. We'll talk the goals of resuscitation and shock, a little bit about the principles of shock management, and then we'll talk a little about vasopressor and inotropic agents, and then finally we'll talk about the differential diagnosis and management of a patient who develops oliguria. So these lectures are all the same. They start with the same with the scenario, right? So here's a 54-year-old man with swollen erythematous leg and purulent drainage. He's febrile, he's tachycardic, he's tachypnic, and he's got a blood pressure of 110/58. He's had no urine output in 12 hours. So here's the question on the table. Does this patient have shock?
Yes.
Yes? Good. So out of these vital signs that you currently see, which one's the most disturbing to you? Which one?
Temperature. Heart rate?
No, respiratory rate.
Heart rate?
Respiratory, I said respiratory
Right.
rate.
So respiratory rate, right? So here's the answer on the post-test question number 1, right? Tachypnea is the most important indicator of critical illness, right? And that's one of the things I don't think that we do well, right? Because not so much in the ICU, but on the floor, if you look at when a patient comes up to the ICU and you go back and you review the medical record, it looks like railroad tracks. Respiratory rate 12, 12, 12, 12. Well, I don't know what happened. The patient just, jumped off the cliff or something. That's not what happened. If somebody actually took their time and counted the respiratory rate, I'm sure they find the patient probably was tachypnic several hours before they fell off the cliff and they came to the ICU. So respiratory rate is huge, and that's one of the things that we should pay attention to when you have a patient who's tachypnic. It usually means something's up. Now, yeah, they can be agitated, they can have anxiety, but the assumption here is that there's something else that's going on, and we got to figure out what that is. Shock is what you're going to find out. It's really all about oxygen. It's all about oxygen. Shock is, no matter what type of shock that you have, right? So shock is defined as a syndrome of impaired oxygen delivery to the tissues, right? And there are 3 mechanisms for that. One, which is absolute relative decrease in oxygen delivery, right? Ineffective tissue perfusion and ineffective utilization of delivered oxygen. And really what our goal is when we take care of patients, we want to optimize oxygen tissue delivery, right, for oxygen consumption, for oxygen balance. So really the way you got to look at this is if we're in the stock market, right, we need to have enough supply of oxygen to meet the demand of the tissue, right? And we do that in a few different ways, and we'll talk about that, okay? So again, the vital signs of this patient. What other clinical or laboratory findings would suggest that this patient has shock? What other things would you look for clinically in a patient who's presenting with shock? By physical exam, what things would you look?
Physical exam?
Yeah, by physical exam. Clinical. What clinical features? They can be lethargic, right? Or they could be agitated, right? They could be agitated, confused, right? Which is very important, especially in the patient population that we take care of, which is mostly older, right? So they can present with lethargy, they can present with confusion, right? So those are some of the things that, you kind of look for, right? Other things, right? Or oliguria, hypotension, mottled skin, those are other clinical findings. And then the laboratory features that we normally look at are what? We look at lactate. What else?
Check blood gas,
check blood gas for metabolic acidosis, base deficit, right? So there are a number of things, and anything that actually interprets in-organ perfusion, even liver enzymes. You see somebody whose liver enzymes are going up, right? They're being on the creatinine, these end organs, right, that now take a hit because of impaired oxygen, delivery, right? And then they start to not work the way that they should, right? So again, these are all the things that you're kind of looking at when you're looking at a patient and trying to figure out whether things are getting better or they're getting worse, right? Okay. So febrile, heart rate, we know, respiratory rate. We got a little bit more information. They're on a non-rebreather. Their O2 sat's only 90%. Their skin's warm and dry. They got a lactate of 4.2, right? And their white blood cell count is 22,000. Right? Okay. So what type of shock does this patient have? So what type of shock do you think this patient has? They have febrile, tachycardic, right? Blood pressure still relatively well maintained. Septic shock.
Yeah.
Good. They have septic shock, right? And most of the patients we care for in the ICU, the most common form of shock we deal with is septic shock, right? Okay, so now this is it. There are 4 classifications of shock, right? There's cardiogenic, hypovolemic, distributive, and obstructive. Right? Cardiogenic, pretty straightforward. Okay, it's either myopathic, mechanical, or it's arrhythmic. Right? You have hypovolemic, very easy, right? It's either bleeding or not bleeding. You can be in hemorrhagic shock or non-hemorrhagic shock, right? For hypovolemic shock. Distributive shock is a little bit more different of a term that we're going to use, right? Not something that you're used to, but there's other things that fall within this category of shock, which is septic shock, adrenal crisis, neurogenic, and anaphylactic. Okay, in terms of distributive shock. Obstructive shock, straightforward. Pulmonary embolism, cardiac tamponade, tension pneumothorax. Okay. Now, it's also possible, and it happens in the ICU, that we may be dealing sometimes with a mixed picture. We may have somebody has cardiogenic component and sepsis and septic, component. It's not uncommon that sometimes you can have a patient that has 2 different types of forms of shock. Okay, but mostly for our purposes, what we could deal with any of these, right? We do deal with all of these in some sense. Maybe as you think about cardiogenic, it's rare, but we do, right? But mostly hypovolemic, because patients can be in hemorrhagic shock that need to be transfused, right? Non-hemorrhagic, they could just be in septic shock and have massive, be under volume resuscitated from the sepsis that they have and need a lot of volume, right? So, and then septic, we know, and obstructive, we deal with patients that have massive pulmonary embolism. We deal with patients that may have cardiac tamponade, tension pneumothorax. Constrictive pericarditis, not so much, but these are the obstructive pictures that you can see with patients who have shock. And interesting enough, with these classifications, of shock, and this is something we learned with the Swan-Ganz catheter, right? So we don't use a lot of swans anymore. It's good news and it's bad news, because it's one of the things that I think that's been taken away from nursing, because the nurses used to be involved in terms of calibrating swans, shooting cardiac outputs, measuring capillary wedge pressure, and had an understanding of what was going on physiologically with the patient based on those parameters, and would come and say, gee, Ronnie, cardiac output is low, wedge is high, you want to start an inotrope. Or, gee, Ronnie, the wedge is low, cardiac output's, low, patient needs volume. What do you want to give some fluid? So it kept them more attuned in terms of what was going on from a physiologic standpoint with patients that we cared for. That's now been kind of taken away, right? So that piece of education, or that piece of your involvement in the care of these patients, for us who's done this for years, it's easy for us to understand this. But for the nurses who's missed out on that, opportunity, and we don't use it anymore, it's something that they're a little bit of a disadvantage when you take care of patients, because you don't have the information, right?
Why don't they do it anymore? Because I know they
Because
stopped when I came in
Yeah,
here.
it
I
doesn't.
did it once,
No, we used to
and
do
then the
all.
next
We
day I
used to do
came
that.
back, it was they took
Every
it
day.
out.
Well, swans,
Yeah.
the use of those catheters have never really ever been shown to change outcome. They've never been shown to change outcome. And the problem with Swan-Ganz catheters is that there's a lot of variables in terms of interpreting that data, right? Is the transducer at the right level? Are you generating, wedge pressure at end expiration? And they did a lot of different studies where they took nurses, doctors, PAs, whoever, in an ICU and said, measure the wedge, right? And what they found was that there was a huge variation from 0 to 30 millimeters of mercury difference between the interpretation of pulmonary capillary wedge pressure. And that makes a big difference in terms of your decision making on what your treatment is, right? So it never was shown to improve outcome, but it did teach us a lot about fluid resuscitation. It did teach us a lot about optimizing cardiac output. But the risk of Swan-Ganz catheters are, infection, pulmonary artery rupture, arrhythmias. There's a whole host of other associated complications that go along with use of that catheter. So it's some places it's still used. Down in the CVRU and the CABG patients, the postoperative hearts, they still use Swan-Ganz catheters, but not so much. So there is news on the horizon, because now there's non-invasive means of being able to generate this data, and in the next month we're going to have that. So you all are going to be looking at real-time cardiac output, pulse pressure, other things that we're going to be looking at, which is going to get you all back into looking at and understanding why we're giving volume, what happens when you give that volume, what the change is, You know, and I think that's going to bring everybody back again because we've kind of lost that, and we need to get back to that, which is what the plan is. Okay. So, your interventions when you manage shock, there are three components, right? There's blood pressure, there's cardiac output, and there's oxygen content. So, all of these you don't get the same bang for your buck in terms of increase in oxygen delivery, right? They're all different. And the bigger one of the three is that clearly when we have a patient who comes up, you know, how do we increase oxygen tissue delivery, right? Well, I just told you. One, increasing oxygen content, optimizing cardiac output, and optimizing blood pressure. So the intervention for those for blood pressure is either giving volume or using a vasopressor or sometimes maybe a vasodilator to try to improve cardiac output. And you look at cardiac output, it's either preload, it's either giving fluids, vasodilator, inotropic agents, vasopressor, or a vasodilator because you're working with preload, contractility, and afterload with cardiac output. And then oxygen content, what's the FiO2 we put patients on when they come back up and they're on septic shock? 100%, right? So you optimize oxygen tissue delivery by increasing the inspired concentration of oxygen. And what we do in the setting is that we give them the most oxygen we possibly can, which is 100% oxygen. Okay? So here, our case study, our patient's getting a little worse. Heart rate's up, respiratory rate's up, O2 sat, lactate's 4.2. What interventions are needed to treat this patient's shock? So what interventions do you think we need to do here for this patient? Okay, so you're going to
Intubate the patient.
intubate the patient, increase the inspired concentration of oxygen. What else?
Fluid.
Give volume, right? Put big lines in, you know, volume resuscitate. What else are we going to do? We're going to send cultures. We want to give antibiotics. You know, we're in the process of doing these things, right? These are the initial interventions that we needed to treat this patient with shock. And again, our goal is to restore tissue perfusion oxygenation. We need to treat a specific cause. Sometimes we start treatment with really understanding what the cause is, or we have to figure out what that cause is, and we got to monitor response, right? And again, the goal here is that we want to be sure that we restore tissue perfusion and oxygenation. So again, you're going to constantly see this word oxygenation, which is really the key. And our goal here is to have oxygen balance, right? Having a supply to meet demand of the tissue. Now the other thing is what we do is that sometimes we send the SCVO2, right, from a central venous catheter. So that's what SCVO2 stands for, right, is venous oxygen saturation. It's not mixed venous. Mixed venous can only come from a small gans catheter. Now, the difference between a mixed venous and SCVO2 is that, yeah, they're both venous gases, but the true mixed venous blood gas comes from a small gans catheter that sits in the pulmonary artery, okay? And then you have blood from the right atrium, you have blood from the superior vena cava, blood from the inferior vena cava, and then it comes up into this wash machine in your chest called your heart, mixes in the right atrium, mixes in the right ventricle, and it goes out the pulmonary artery, and right before it goes out into the lung, it gets oxygenated where you draw your sample. Well, that's why it's called a true mixed venous. Because if I put a catheter in your SVC and if I put a catheter in your IVC and I sent two specimens, would they be the same? No, they won't be the same, right? So there is a correlation between SCVO2 and mixed venous oxygen, and we use it, right? But it's not a mixed venous; it's a venous oxygen saturation, right? So normal mixed venous oxygen saturation is what? What's normal mixed venous oxygen saturation? When we draw that blood gas, you all look at it. What's normal mixed venous oxygen saturation?
That between 35 to 55.
So mixed venous oxygen is 40, right? And mixed venous oxygen saturation is 70%, right? So 70% is normal saturation, and normal mixed venous oxygen is 40, right? So that's going to give you an idea about enough supply to meet the demand of the tissue. So why do I say that? So let's take a patient in cardiogenic shock, right? What would you expect the mixed venous oxygen to be? High, low, or normal in somebody who's in cardiogenic shock? Low. Good. Very good. Why?
Because patient is in that process, so the tissues are demanding more oxygen, which the body is not able to supply.
Okay, good. So the answer is that I think that's absolutely correct. So the way I look at this is that all of us, maybe at some point, I'm going to date myself, has played the game Pac-Man. You know Pac-Man? You know, the thing is eating the fruit. You know, he's going. right? So what happens in this particular situation is you're absolutely right. So you got a patient who's in cardiogenic shock. They have a low cardiac output. So whatever's being delivered in the tissue is hungry. It's starving for oxygen. So what happens is that you got maximal extraction